Hello everybody, Dr. Gillard here. It is Thursday. It's week 7. It's the winter of 2022, and here's our CVPP lecture for today. And here we go. We'll start off talking about infective endocarditis. So infective endocarditis is basically an infection of the very inner layer of the heart, which is the endocardium. And the endocardium, of course, there's an endocardium, myocardium, and pericardium. Pericardium is on the outside of the heart. The myocardium is in the middle. The endocardium lines the inside. It's made of endothelial cells. It's just the same. It's like blood vessels, only it's inside of the heart. And so it's also, I should explain this word, mural endocardium. So the mural endocardium, I like that word, by the way. Make sure you know that mural endocardium is the endothelial lining of the heart chambers, but does not include the lining on the valve. The valves are also lined by cells, but the mural endocardium is just the lining of the chambers. But this infection can affect the mural endocardium as well as the heart valves itself. So the entire heart, like you can see the valves, the mitral valves are infected by these crazy looking bugs here as well. All right, the bugs can also, if the infection gets bad enough, it can also get into the myocardium and start to destroy and inflame the myocarditis. After the infection heals, if it does, remember fibroblasts come in and lay down collagen, and it scars up your heart. It makes it so your heart doesn't pump very good anymore. So it can be a cause of heart failure or cardiomyopathy. All right. Another problem is the bugs can lead to vegetations. There's another new word for you, vegetations. These vegetations can break loose and cause embolisms, septic embolisms. So just picture maybe, let's say this one right here. If this group of them gets big enough, it can break loose and become an embolism, and it can get shot up here and go up into the brain and cause a stroke. Or it can go back in the coronary artery and cause a myocardial infarction. It can go anywhere. So those are called septic embolisms. They're made of bugs, right? All right. And not only bugs too, but there's going to be thrombus. If you have inflammation here that's filled with bugs, you're going to start getting blood clots there as well. So thrombus formation will occur. All right. All right. The most common type of bug is a bacteria, and we'll look at them in a minute. But if you do know, if you've done histology and you know the bug, then that's called bacterial endocarditis, if you know it's a bacterial infection. There is the difference between acute and subacute. We could kind of subcategorize this. A new infection of a previously normal heart, brand new on a normal heart, is called an acute infective endocarditis. This is typically caused by a virulent strain of Staphylococcus aureus. Staph aureus is responsible for about 25% of these acute infective endocarditis episodes. And these aren't good because they can lead to heart valve destruction if the inflammation gets that bad. Let's see. And these are resistant too. These can be antibiotic resistant. And it can be, if that's the case, it can be not a good thing. And ultimately, if this gets bad enough, it's going to require some type of surgical cleanup procedure. And if that's not worse, it can be fatal as well. Now, a subacute infective endocarditis, that's caused by a bug as well, but the bug is not as virulent. It's like it's a bug that causes inflammation, but it doesn't multiply as fast. It doesn't stimulate quite the severe inflammation like Staphylococcus aureus does. So Viridian streptococci is a common example of kind of a medium virulent type organism. So it's still trouble. It could still damage the heart, but it's less destructive. It can still deform the valves of the heart. Probably not going to die from this one. Antibiotics have a better chance of helping this condition. And there's less sequelae from this as compared to the acute version as well. We'll look at some sequelae. Actually, we'll look at risk factors first. So what increases your chances of getting infective endocarditis? The big one here is rheumatic heart disease that you've had probably as a child. So this is a major precursor here. Heart valve prolapse for any reason. Maybe it's from rheumatoid heart disease, but you could be born with it as well. You could be born with degenerative disease of the valves, stenosis, with calcium, without calcium. So any valve disease. Bicuspid aortic valve, it's another valve. You're born with 2 instead of 3 cusps. Artificial heart valve always increases the risk. And then our friends, the cyanotic heart diseases, or the congenital heart wall defects, the atrial septal defect, the ventricular septal defect, patent foramen ovale. Remember that little controversy on a patent foramen ovale, though. Some, including the chiropractic board authors, they don't classify it as a congenital heart disease, the PFO. It's more acquired, but nevertheless, it can still be trouble. What's the source of the infection? Well, you have to get an infection somewhere else first, and then it travels to the heart from some other region. So the lungs could get infected. It could start as pneumonia, staphylococcus-based pneumonia, a cellulitis from a cut on the skin, maybe a peptic ulcer disease where you get a hole in your stomach or duodenum, and then you get intestinal contents, including bacteria and such, drained out into the peritoneal cavity, and then they get into the bloodstream. It's kind of a precursor to septicemia, that one. Dental procedures. Anytime you puncture the skin and bug skin. Clinical presentation. Patients, it's classically said, Robbins says, it has a stormy onset. These people get sick and they go down here really fast, so especially a fever is the number one sign. Chills, weakness. Lassitude, there's another vocabulary word for your lassitude. So that's lethargy. Just kind of flu-like symptoms. You don't feel well. Malaise, you just don't feel well. Flu-like symptoms. People, especially if the left ventricle is involved, they'll have an auscultable murmur about 90% of the time because of turbulent blood flow. The inflammation will start to affect the flow of blood through the heart, and it'll start to cause a rapid flow, and you should be able to auscultate that most of the time. And then, of course, you'll do, that's kind of out of place, but you'll do blood work to find out what type of bug it is before you give them antibiotics. That should be under treatment. What about complications? It's as if this isn't complicated enough by itself. So the bugs can go to another place. So you got pneumonia, and now you got an inflammation of the heart because the bugs got there. And the body mounts an immune response against the culprit that's located on the heart. And for whatever reason, that immune response it sometimes gets confused and it hits the glomerulus of the nephron. And so you can get a glomerulonephritis, which is not good. It can permanently damage the kidneys. That can cause hypertension by turning on the R2A system when it doesn't need to be on. And we usually don't have time to make it that far to glomerulonephritis, but it's not a good thing. It can ruin your kidneys. More complications, the bugs can build up and invade the blood and cause septicemia. We already said the bugs can break loose out of the heart and they can form an embolism, a septic embolism, which can cause myocardial infarction, stroke, liver infarct, spleen infarct, stomach infarct, intestinal infarct. Just depends where the embolus goes. All right, so that's the end of that category. Let's get into coverings of the heart and their disease, namely the pericarditis. So a little quick anatomy review. The pericardium, of course, is the sac that is around the heart. And it's really 3 layers of tissue make this thing up. But there's 2 main layers of tissue, and then there's a space in between here that's important. So the sac contains the heart. It also contains, importantly, the proximal part of these great vessels. See, this is welded right here. So if we pour fluid in here, or fluid accumulates in here, it can't get out here. It doesn't leak out. This is welded shut. Who are the great vessels, by the way? And the point was the pericardium is around the proximal part of the great vessels. Great vessels are the ascending aorta, superior vena cava, pulmonary trunk, and inferior vena cava, although some authors don't include that because the root is not covered by the pericardium as deeply as it is the other vessels. Here's just a close-up of that. Remember, we've talked about aneurysms and how they can leak in here. Actually, we'll make that more official in a little while, but this whole space can fill up with blood and you can get a cardiac tamponade, which is quite dangerous. And here's the tri-layers. I mean, you can't see it very good. Don't have a blow-up. Here we go. Let's look at this. Here's the 3 layers. Here's the endocardium. Endocarditis, we just looked at an inflammation of this layer. The blood is in here, circulating around. There's the myocardium, where the smooth muscle cells are that power the heart. And then we have 2 main layers. We have a serous pericardium that has 2 layers. There is a visceral pericardium that is also called the epicardium. We have then we have the parietal pericardium, serous pericardium. And the important take-home message here, there's a space between the visceral and serous pericardium where fluid goes. There's little cells right here, and they secrete serous fluid, which is a slippery, slimy little fluid, so friction doesn't build up between the sac around the heart and the smooth muscle of the heart itself. Then we have a fibrous pericardium on the outside. It doesn't have 2 layers. I don't know why the author drew 2 layers. That does not have 2 layers, though. That's very stiff and non-forgiving. It'll stretch if you stretch it slowly over time, but if you stretch it quickly, it won't. Well, if you try to stretch it quickly, that doesn't work. So why or when does the pericardium become clinically important? Well, anytime it fills up with blood, the pericardial cavity becomes clinically important, like a retrograde dissection specifically. So again, because the pericardium covers the root of the aorta is where the aorta attaches to the heart, like a Stanford A or DeBakey 1 or DeBakey 2. If you get a retrograde, a backwards dissection that goes not away from the heart but towards the heart, and it ruptures, you could get a bleed into the pericardial cavity, and that could quickly fill this entire space up with blood to the point it starts pushing down on the myocardium and starts squeezing the heart. and that's called cardiac tamponade. Cardiac tamponade. And yes, they're back. Oh no, the dreaded dissecting aneurysms are back. Yep. So these are on the final too. So make sure you remember what a Stanford A, Stanford B is. Stanford A means that the dissection is at least, it has to be in the ascending aorta. And it doesn't matter if it goes further or not. If it's in the ascending aorta, it's a Stanford A. If it goes into the arch, still a Stanford A. If it is in the ascending aorta and in the descending aorta, still Stanford A. Stanford B, it cannot be in the ascending aorta. DeBakey 1, DeBakey 2, DeBakey 3. DeBakey 2 is the easiest one to do first. It can only be in the ascending aorta, extremely dangerous. DeBakey 1 means it's in the ascending aorta and it has to extend somewhere else, probably into the arch, but maybe not. Maybe just a little piece here, the descending aorta, but it has to extend. DeBakey 2, it's only here. DeBakey 1, it's in the ascending aorta and it has to extend. DeBakey 3 means it has to be in the descending aorta. Okay, cardiac tamponade, again, when the fibrous pericardium is filled up quickly with fluid, and it doesn't have to be blood, it could just be serous fluid from a really irritating inflammation or infection. If it fills up enough, it can squeeze and compress the heart to the point you can't eject blood you can't fill the heart and eject blood anymore. And that's, of course, called cardiac tamponade. And there's a cartoon of a heart that's just filled up with blood. And the heart is squeezed, and the blood coming out is not great. Patient has hypotension. Let's do a case here. 57-year-old enters your clinic with a worsening chest pain, dyspnea on exertion. Heart rate is about 120 beats per minute, so it's a tachycardia. He's not sweating. And you take a chest film. This is just to remind you what a normal chest film looks like. There's a normal-looking heart. Takes up like about a third of the area of the thorax here. Costophrenix angles are sharp down here. Okay, now here's our patient's chest film. And you're like, whoa, that's way too big, right? Look at how huge the heart is. That's taking up way more than a third. So yeah, that's no good. He ended up having a Stanford A dissection that was bleeding into the pericardial cavity, and he started getting shocky because he didn't have much blood being ejected from the heart anymore. All right, pericardial cavity. Some fun facts about it. It normally has a little serous fluid, 15 to 50 milliliters, 30 milliliters on average, and it's a slippery type fluid, prevents friction, we said. It's normally secreted by the serous pericardial cells, which are simple squamous. They're classified as simple squamous cells, but they're just serosal cells. And there's a couple different flavors of pericarditis we need to talk about. There's acute pericarditis. That is the most common condition of the pericardium, and as the word itis means inflammation, that means that it's an inflammation of the pericardium, maybe all 3 layers, maybe 2 layers. And it's a problem because it can present just like a heart attack. It causes anterior chest pain or precordial pain. It's seen in about 5% of people who enter the emergency room. But the scary differential diagnosis here is GERD, or that's not scary. Myocardial infarction is scary. But GERD, I like this question. Pericarditis, GERD, and myocardial infarction can all cause anterior chest pain and burning. And so it can be confusing. There's 2 general categories of acute pericarditis. There's infectious and non-infectious. Both of these conditions, however, result in inflammation. And inflammation irritates the serous cells or serosal cells, and it causes them to overproduce serous fluid, and it can get so bad that you can start to get tamponade from that condition. All right, so let's look at the infectious pericarditis. Kind of a busy slide. I guess I should have split this slide up. I say that every quarter, don't I? Infectious pericarditis. So that's a bug has gotten into the heart somehow or into the pericardium, and it's irritating the cells of the serous pericardium to the point that they start overproducing serous fluid from the irritation. Plus you have an inflammation, you have inflammatory fluid and exudate dripping in there as well that compounds the problem. We should note that the serous pericardium is really made up of, did I say serosal cells? There's no such thing as that. It's mesothelial cells is what it's made up of. And those are very similar to endothelial cells that we've talked so much about. Mesothelial cells and endothelial cells are both simple squamous. You could classify it as simple squamous. All right? And yeah, if that fluid builds up enough and quick enough, it can cause cardiac tamponade. If it builds up slowly, it can make the heart stretch. It can make the pericardial cavity stretch to gigantic proportions if there's a slow buildup. Who are the bugs? Bacteria, from pyogenic bacteria like Staphylococcus aureus, that menace. Pneumonia, bunch of them. Those are the big ones. It could be a virus, could be idiopathic, meaning we don't know what caused it, but it probably was a virus that, for whatever reason, escaped the biopsy results. In fact, idiopathic is the most common cause of pericarditis. They go drain some fluid out of the pericardium, culture it, there's nothing there. Tuberculosis is another one that can cause it, more in third world countries. So non-infectious pericarditis means it's not caused by a bug. There's still an inflammation, but it's not caused by a bug. Something else sparks the inflammation. What could that something else be, we wonder. It's usually autoimmune attack against the serous or fibrous pericardium. So rheumatoid arthritis, the patient has concomitant rheumatoid arthritis, and for whatever reason, all of a sudden it attacks the pericardium. Lupus, scleroderma, these are all autoimmune diseases that can attack the pericardium as well as other regions of the body. Cancer, metastatic disease, very poor prognosis, but cancer cells wandering around through the blood stream can get stuck inside the pericardium and grow there, and their growth sparks an inflammation, and their growth also can have a mass effect on the heart. Uremic pericarditis, from uremia, that's a failing kidney. Parts of the kidney can start breaking down and getting into the blood. It's circulating, and they can get stuck, just like cancer, just like a bug. Those breakdown products of the kidney can get stuck inside the pericardium and spark an inflammation. Autoimmune disease, we already talked about that. Rheumatoid arthritis, scleroderma, lupus, they're all autoimmune diseases. Well, we know what that is already, don't we, from Dr. Doe, who's taught you that the body attacks tissue that it's not supposed to attack. Or maybe starts out as inflammation, the phenotype of some cells are permanently changed, and the body no longer likes the look of those new cells and attacks. Yeah. I've talked about that already. So non-infectious, what about some other causes besides the one we've talked about? Chemotherapy, radiation can also irritate the pericardium, those mesothelial cells. Can irritate them into overproducing fluid. A status post myocardial infarction, especially a superficial myocardial infarction, can do it. It's the cleanup of the inflammation. If you have a heart attack, you have dead tissue that needs to be cleaned up. How do you clean up the dead tissue? How do you clean it up is through inflammation. And yeah, the inflammation, especially in the superficial part of the heart, close to the pericardium, can spread into the pericardium like a fire can spread into a nearby canyon where it's not supposed to be. We talked about this uremic pericarditis is kidney breakdown products can get into the pericardium, into the pericardial cavity, and spark an inflammation. Some of those breakdown products include urea, creatinine, uric acid, plus proteins that just break down from the nephron and get into the bloodstream. What's the blood findings of someone with uremic pericarditis? Well, they'll have an increased BUN, blood urea nitrogen, will be high, and creatinine will be high, or you could just say that they have increased blood nitrogen. But when you learn when you have your lab, your hematology lab, you'll learn about BUN and creatinine levels. Maybe you've already had that. And there's a name for this. When your blood nitrogen levels increase, so when you have an increased BUN and creatinine levels are increased, you're diagnosed with azotemia. Azotemia, make sure you know that word. That means increased blood nitrogen products. Myocardial infarction kind of gave this away already, but yep, there is some myocardial infarction associated. Non-infection pericarditis. There's actually two types, an early one and a delayed type, or Dressler syndrome. Let's go through those. Let's take the early one first. Usually occurs 1 to 4 days after a myocardial infarction, and this is what the one I just explained, especially a superficial or a pan myocardial infarction where the entire wall of the heart's been damaged, but occurs between 1 to 4 days. And what happens is your heart dies, and your body mounts an inflammation against the dead tissue to clean it up, and the inflammation gets into the pericardium, and that's it. That's what it is. More common in the superficial myocardial infarctions and very large area myocardial infarctions. The prevalence is not small. It's 10% of people with a heart attack can have this kind of secondary problem with inflammation of the pericardium. It can be dangerous. I always ask this question. This is a high yield right here. These early type myocardial infarction associated pericarditis, it can be dangerous. And the inflammation itself is not what's dangerous, but the pain of the pericarditis, which occurs, let's say on day 3, you get another pain, and you think you're having a heart attack, and you get worked up, and you get diagnosed with pericarditis, and that's where the pain is coming from. But that pain may mask another heart attack. If you've had one heart attack, if you had one MI, you can have another one, especially within that first 6 weeks. And so on day 3, you had another bout of pain. You're diagnosed with pericarditis. On day 4, you have another bout of pain, but they think it's just the pericarditis. But unbeknownst to them, you had another secondary heart attack that wasn't treated, and you die. So the danger of pericarditis is the pain can mask the start of a second heart attack. Dressler syndrome, I like this one too. This is a strange one. So it's a late onset of the same thing. You get a pericarditis, but it doesn't come till about 5 weeks after a heart attack. Right? Occurs in about 4% of people who've had a myocardial infarction, so not quite as common. The etiology is not completely understood. It's probably autoimmune to the damaged myocardium that was cleaned up by an inflammation, and some of the cells' phenotypes was changed, and now all of a sudden the body doesn't recognize them anymore and attacks them. And somehow these new genes, we don't know how they got turned on, but everything I said there. All right, what are the clinical findings of pericarditis? Chest pain. But there's a specific type of pain that is typically there. It doesn't always have to be there, but there's a specific type of pain that is usually there, and that's called pleuritic chest pain. Pleuritic chest pain. Make sure you know that. It's literally, I've had this before when I had pulmonary embolisms. It's also common in pulmonary embolisms when they cause an infarct. I had it about 5 days after my pulmonary embolisms were caught and treated. I got an infarct of part of my lung, and it was the worst pain. I've had broken ribs before. It was worse than broken ribs. I had to go to the ER. Morphine didn't help, and they put me on, what did they put me on? I forget what it was, but it did take the pain away, that second one. Really bad pain, and you can tell it's pleuritic chest pain because you can't breathe. You can't breathe in. Inspiration is severely, severely painful. There's a lot of coughing that can be involved, but it's pain and inspiration, a stabbing, sharp pain. You have to breathe shallow in order to breathe. So pulmonary embolism should be ruled out on that as well. Other clinical findings, you might have a fever triggered by the inflammation. You might have dyspnea, trouble breathing. You may have an auscultatory sign. People with pericarditis often have something called a friction rub, which is, I'm not going to play it here, but you can go check out friction rub. Google friction rub, auscultatory sounds, and there's a bunch of them in there. And it's a sound, it's an extra heart sound that's heard over the top of lub-dub, lub-dub, lub-dub. And I can't even demonstrate it because I'd need two voices. The lub-dub keeps going, and there's it's a three-part sound really. It's like a ch, 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 ch. But it almost sounds like static going over. It's best that you just go listen to it, better than listening to me try to do it. But yeah, let's talk even a little more about it. This sound, when it's fully mature, there is one systolic sound and two diastolic sounds that can be heard on top of your S1 and S2 heart sound. For chiropractors, we are going to auscultate for this at Erb's point. Some of the medical texts say it's best to auscultate this in the left lower peristernal border, so the fourth and fifth intercostal spaces peristernal border on the left. For chiropractors, that's Erb's point, or even the base of the heart, but we'll go with Erb's point. And yeah, when fully developed, it has one in systole and two in diastole. Some people say it sounds like leather straps kind of rubbing across each other in those three instances. But it muffles the regular heart sound, so you can't make out lub-dub very good anymore. I threw this in here so I can test you on it. Don't forget the auscultation zones: aortic, pulmonic, Erb's point, tricuspid. Tricuspid is either in the fifth intercostal space, left peristernal border. Some texts say the fourth or the fifth intercostal, because honestly, it's really hard to tell where you are when you're auscultating down here, so I think it's more correct to say this left lower sternal border. Then the mitral area out here. So base of the heart, remember, is the second intercostal space. Pericarditis versus myocardial infarction pain. Well, when you get technical, they can be told apart, but you can't rely on that because people with pericarditis don't always have pleuritic chest pain. But if they do have that stabbing pleuritic chest pain, it's probably not a myocardial infarction, because those people, they typically don't have that type of pain. And even more confusing, you would think you could use EKG or ECG to tell them apart, but sometimes you can't, because they both can have ST segment elevation. Here's someone, they could be having a STEMI myocardial infarction here. You can see the ST segment is quite elevated. It didn't come back to the isoelectric line. This happened to be a patient with pericarditis, so the EKGs are with the ST segment elevation can be seen in both, so you can't rely on that to tell them apart. In fact, ECG is 90% abnormal with that ST segment elevation in people with pericarditis, so very weird. It messes up the electrical signal. All right, let's finish up here. Almost done. Finish up with cardiac tamponade. And remember, it's when here's another picture from Wikipedia where the heart is filled up with a serous fluid and it's squeezing the heart. Cardiac tamponade is squishing the heart because of fluid or a blood or some type of buildup of fluid in the pericardial cavity itself, and it crushes the heart, and that decreases stroke volume. All right. Yeah, pericarditis can cause cardiac tamponade if it's severe enough, because any pericarditis is going to produce extra serous fluid because inflammation irritates those cells that line the serous pericardium, those mesothelial cells, cause them to secrete that serous fluid. And it doesn't always, but if it accumulates rapidly, anything over 50 milliliters of pericardial fluid, you're on your way to cardiac tamponade and start to have symptoms of chest pain. Yep, everything I said. If it comes on rapidly, as little as 200 millimeters of fluid can kill you. It can squeeze the heart if that comes on really fast. What causes cardiac tamponade? Well, we just said pericarditis can do it, but any type of fluid buildup in the pericardial cavity can do it. So it can be a pus. Maybe you have some type of infection that's really producing a lot of pus. So you could have a pyopericardium. Pericardial cavity filled up with pus can squeeze the heart. Blood from a DeBakey 2 aneurysm can do it. Or from a stabbing injury to the heart. Or a motor vehicle accident where you get a concussion injury and you rip the descending or ascending aorta and it bleeds. It's possible to get gas if you get a fistula, an abnormal communication between the pericardial cavity and the lungs, or the transverse colon. It's possible to get air filling up the pericardium, or maybe from a penetrating injury could do that as well. It's called a pneumopericardium, hemopericardium for blood, pyopericardium. Really easy for me to make test questions on that, so make sure you know those. Some other causes is the same causes as the pericarditis. We've already talked about cancer, infection, uremic pericarditis. If it's severe, it can cause a fluid buildup in the pericardial cavity to the point it squeezes the heart. Rheumatoid disease, we talked about, same things. Is it a systolic or diastolic problem? It's not a systolic problem. Remember, when the heart beats, unlike making a bicep, flexing your bicep muscle where your bicep gets big, when you flex your heart, it gets long and skinny. The problem is diastole. Your heart will be squeezed in that long and skinny position, and it can't stretch to accommodate new blood. So it's a diastolic filling problem. And if you can't fill the heart, you have a decreased stroke volume or ejection fraction, and your blood pressure is going to drop, and that's the problem with this. Beck's Triad, you should know. Triad means there's 3 classic symptoms that demonstrate cardiac tamponade is present. And you don't typically have all 3, but you usually have 2 of these is enough. So hypotension from the strangling of the heart from the cardiac tamponade, talked about that. Auscultatory finding of pericardial friction rub and extended jugular veins. Now, how can that happen? Well, the heart is a beaver dam. If you can't get blood to fill the heart, where's that incoming blood going to go? It's going to back up into the lungs, right? And so your jugular veins are going to bug out. And we'll talk more about pulsus paradoxus and Kussmaul's sign. Kind of expand on that. But that's Beck's Triad, so note card. Make sure you know that. How about any other signs of tamponade? Well, we just said hypotension. If you have hypotension, there's signs related to hypotension. That means not enough oxygen is going through the body, not enough blood carrying oxygen, and so the heart's going to beat faster. So you'll have tachycardia. If you have tachycardia, you always have tachypnea. You might, because of the beaver dam, you might be getting some blood fluid draining into the alveoli and up into the tracheobronchial tree, which stimulates a cough. Might even have some pink frothy sputum coming up. Yeah, you could go into shock because of the hypovolemic shock. You could call this an obstructive shock because the heart is being squeezed. It's like an obstruction. But it's really a kind of a hypovolemic type shock. And you could die from this. What about renin levels? Yeah, they're going to be elevated, right, to fight the hypotension. Okay, look at this one. So this is a guy who had severe cardiac tamponade, but it came on really slow. It was metastatic disease. Some cancer cells started to get into the pericardial cavity. Pericardium, the fluid was slow but steady. And we said if the pericardial cavity fills up slowly, it can accommodate and stretch. And this is this crazy big, right? It's all fluid in there. Treatment is to get the fluid out. You do something called a pericardial centesis, and they take, just like this picture, they take a needle very carefully and put it in here, being careful not to stab the heart, and drain out the fluid. Send it to the lab and biopsy it. All right, that's enough for your brains. We will see you next week. We'll be week 8 next week. Oh, I forgot to add a bird, didn't I? Oh, darn. All right, I'll do that next week. See you later.